Hello everyone, I'm Dr. Mustafa Afifi and today we will be talking about cardiogenic shock for USMLE purposes. We will be discussing the definition, pathophysiology, clinical finding, causes, and last but not least we will be discussing a case presentation. So to start, what is our definition? A cardiogenic shock is inability of the heart to pump enough blood to meet the metabolic demands of the body. It's caused primarily by a cardiac dysfunction rather than lack of blood or systemic vasodilation. What is our causes? Our most common cause is myocardial infarction, followed by severe or decompensated heart failure. And another common cause is arrhythmias like VTAC or VFib. Acute valvular problems, myocarditis and endocarditis are rare causes of this type of shock. What is our pathophysiology? Our pathophysiology mainly is ventricular dysfunction, systolic or diastolic dysfunction, meaning that not enough cardiac output is present, so decreased cardiac output, leading to organ perfusion being low. What is our compensatory mechanism? Our body will try to compensate by increasing systemic activation and by activating the nervous system, leading to systemic vasoconstriction and increasing the systemic vascular resistance. What is our consequences? Organ hypoperfusion, and blood will start to accumulate in the veins. The two veins, the systemic venous congestion leading to peripheral edema and jugular venous distension, and the pulmonary congestion leading to pulmonary edema. So, what is our typical finding? Cold clammy skin due to low cardiac output and vasoconstriction, hypotension, tachycardia and tachypnea as a compensatory mechanism, jugular venous pressure, pulmonary crackles as a response to pulmonary congestion, S3, S4, and murmurs. Our finding in pathophysiology will be low cardiac output, increased pulmonary capillary wedge pressure, increased venous return, and increased systemic vascular resistance. How can we differentiate this cardiogenic shock from other types of shock? First, we assess the perfusion. Cold and warm shocks. In cold shocks, the problem is mainly low cardiac output with vasoconstriction, which is seen in three types of shock: cardiogenic, hypovolemic, or obstructive. In warm shocks, the problem is disruptive vasodilation due to toxins in septic, due to histamines in anaphylactic, due to loss of sympathetic in neurogenic. After that, we assess the jugular venous pressure in cold patients. If it's elevated, high jugular venous pressure, it's either cardiogenic or obstructive. If flat jugular veins are present or low jugular venous pressure in a cold patient, it's hypovolemic. Last but not least, we examine the pulmonary findings. If pulmonary crackles associated with S3, S4 or murmurs, this is most likely cardiogenic shock due to pulmonary congestion. If no crackles are present and distant heart sound, we think cardiac tamponade. If absent breath sounds after a trauma, you think tension pneumothorax. So murmurs, S3 or S4 will point us to cardiogenic shock. Meanwhile, crackles will also point us to cardiogenic shock and are rarely seen or almost not seen in obstructive shock. What is our case? A 72-year-old with severe chest pain and history of hypertension and hyperlipidemia. So this history and presentation makes us think of MI. He has cold clammy skin, so it's low cardiac output. Jugular venous distension, so it's either cardiogenic or obstructive. Diffuse pulmonary crackles, making it most likely cardiogenic. Our stepwise reasoning, as we said, cold, so low cardiac output, cold shock, one of the three. Jugular venous pressure, so it's either cardiogenic or obstructive. Pulmonary cracking, cardiogenic, and the history of MI symptoms seals that as cardiogenic shock. Our conclusion: a cardiogenic shock presents with decreased cardiac output, increased systemic vascular resistance, and pulmonary congestion. Our summary table differentiating between different types of shock. Cardiogenic, hypovolemic, and obstructive are three cold shocks. Meanwhile, disruptive, septic, anaphylactic, and neurogenic are warm shocks. Next, we look at jugular venous pressure. High in both cardiogenic and obstructive, and low in hypovolemic and disruptive. Pulmonary edema is present in cardiogenic and absent in both hypovolemic and obstructive. So a cardiogenic shock is a cold shock with congestion and pulmonary finding, differentiated by skin perfusion, as we said, cold, jugular venous pressure high, lung finding, and history. Common causes are MI, arrhythmias, acute valvular disease, and myocarditis cardiomyopathy. Thank you for listening and good luck.